It's time for the 3-question warm-up for Psych 2. Let's get going. A patient presents with hyperphagia, hyperorality, and hypersexuality. What is the diagnosis and what brain lesion can cause this? So this is your Kluver-Bucy syndrome, which is caused from bilateral amygdala lesions. Next question. What are the most common causes of seizures in young adults, specifically 18 to 35-year-olds? So this is going to be trauma, alcohol withdrawal, and then brain tumors. Next, what is the treatment for cluster headaches? So the key here is 100% oxygen on a non-rebreather for about half an hour. You can also use the same drugs that you use for other migraines like triptans and dihydroergotamine. All right, that's going to be it for the warm-up. Let's get to that video.
In this video, we're going to cover the antidepressants, which are used to treat depression, obviously, but they're also commonly used to treat anxiety disorders and lots of other psychiatric diseases. So you definitely need to be familiar with these drugs. First off, you need to be able to recognize which drugs belong in each class of antidepressants. Now, we're going to talk about the features of the various classes shortly, but first, take a look at the study guide. I want you to try to group the different drugs as SSRIs or SNRIs or tricyclics or MAOIs and so on. So pause the video, try to do that on your own, then we'll go over them together. All right, the selective serotonin reuptake inhibitors, or SSRIs, include citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, and sertraline. The SNRIs are serotonin norepinephrine reuptake inhibitors, and these include desvenlafaxine, duloxetine, milnacipran, and venlafaxine. The atypical antidepressant group is kind of a grab bag grouping, and it includes bupropion, which is called an NDRI, a norepinephrine dopamine reuptake inhibitor. There's mirtazapine, which is an alpha-2 adrenergic antagonist, and nifazodone and trazodone, which are called serotonin modulators. But these are all drugs that are used fairly commonly. But that's not true of these last two classes, TCAs and MAOIs. These are hardly ever used for depression anymore because of side effects, as we're going to see. The TCAs, or tricyclic antidepressants, include amitriptyline, doxepin, imipramine, and nortriptyline. Now there are some others like clomipramine and disipramine, but those weren't listed in this question. And then the MAOIs are monoamine oxidase inhibitors, which are phenelzine and tretilcipramine. Next, we're going to go through each class of drugs one by one in this big table in your study guide. And the two things I want you to focus on are the mechanisms of action and the common side effects. Now for the mechanism, remember we said that in depression you tend to have low serotonin, low norepinephrine, and low dopamine. And all these drugs are going to increase one or more of these neurotransmitters. So the first group are the SSRIs, selective serotonin reuptake inhibitors. So they block the presynaptic reuptake of serotonin, so you have more serotonin hanging around in the synaptic cleft. SSRIs are the first-line treatment for depression and also for most anxiety disorders, because anxiety is also associated with low serotonin. But unfortunately, the SSRIs take at least 3 to 4 weeks to start working. You may not see full effect for 6 to 8 weeks. I usually start a patient on an SSRI and then tell them I want to see them back in a month or so to make sure they're not having any side effects. But I tell them I don't expect them to really feel any better in a month, because it takes almost a whole month before the drug really starts to kick in. Now the side effects include sexual dysfunction like loss of libido, anorgasmia, and erectile dysfunction. Definitely remember the sexual side effects with SSRIs and also SNRIs. SSRIs can cause vague problems like insomnia and agitation and weight gain. But overall, these are much better tolerated than some of the older antidepressants like TCAs and MAOIs. And it's important to know that the SSRIs can increase the risk of suicidal ideation in children and adolescents and young adults. Another important side effect of SSRIs is the increased risk of serotonin syndrome. And not only with SSRIs, but also SNRIs, because they're both going to increase serotonin levels. Serotonin syndrome is caused from an excess of serotonergic activity. Now, this may happen at therapeutic doses, but for the most part, we're talking about people who are taking more than one serotonergic medication at a time, or people who overdose. Now, we're going to come back to this table in a moment, but first let's skip down to number 6 and talk about serotonin syndrome. So what are the characteristic features of serotonin syndrome? What are we looking for? Well, you can have mental status changes like anxiety, agitation, delirium, restlessness, disorientation. The next bullet is autonomic excitation, such as diaphoresis, tachycardia, hyperthermia, hypertension, nausea and vomiting, and diarrhea. These are all just symptoms of autonomic excitation in general. You can also see neuromuscular hyperactivity, which could present as tremor, or muscle rigidity, hyperreflexia, or myoclonus. But if you see a patient who's delirious and hyperthermic and has myoclonus, I want you to think about serotonin syndrome. Then the next blank is ocular clonus, which is slow, continuous horizontal eye movements. So clonus or spasm of the extraocular muscles. And this myoclonus can either be spontaneous myoclonus or inducible myoclonus. The next question says, which drugs increase the risk of serotonin syndrome? So basically anything that can increase the level of serotonin, either used alone or in combination, could lead to serotonin syndrome. So this would include most of the antidepressants, including SSRIs, SNRIs, MAOIs, TCAs, St. John's wort, which is an herbal supplement that lots of people take over the counter for depression because it raises serotonin and norepinephrine and dopamine levels. And people also take the amino acid tryptophan to treat depression because it's a precursor for serotonin. And there are also some important non-psychiatric medications that can contribute to serotonin syndrome. For instance, the triptan drugs that we use for migraines, like sumatriptan, are serotonin receptor agonists. The antibiotic linezolid is one that seems to come up on board exams from time to time. Levodopa can affect the balance of dopamine and serotonin. And then other drugs that can contribute to serotonin syndrome are stimulants like cocaine and amphetamines, and also ecstasy. So if you're mixing recreational drugs with therapeutic drugs, you could have some problems. Then the next question asks, what's the treatment for serotonin syndrome? So first of all, you definitely want to discontinue all serotonergic agents. You want to do supportive care to normalize the patient's vital signs, things like oxygen, fluids, cardiac monitoring. If they need treatment for hypertension or tachycardia, you can use a short-acting agent. You can sedate the patient with benzodiazepines. If the patient's hyperthermic, you should paralyze the patient and then cool the patient off. This hyperthermia is caused by all this neuromuscular excitation, so the paralysis should help to resolve the hyperthermia, but there's no benefit from antipyretics. And if they continue to be agitated despite the benzodiazepines, you can use a serotonin antagonist like cipraheptadine. And then after the symptoms resolve, and they normally do, but this could be fatal, but after the symptoms resolve, you have to assess whether or not you're going to resume the serotonergic medications. Then real quick, you should also know the difference between serotonin syndrome and neuroleptic malignant syndrome, which is a side effect of antipsychotic drugs. Now, both of these cause autonomic instability and hyperthermia and muscle problems. But an important distinction is that serotonin syndrome is definitely characterized by rapid onset of hyperkinesis and overactivity and clonus. Neuroleptic malignant syndrome has more gradual onset and bradykinesia, or slow movements, and lead pipe rigidity. So lead pipe rigidity for neuroleptic malignant syndrome, and clonus is for serotonin syndrome. Let's go back to the table and look at the SNRIs, which are serotonin norepinephrine reuptake inhibitors, like venlafaxine and desvenlafaxine and duloxetine. Now, these aren't used quite as often as SSRIs because they're a little bit newer, but they do get used a substantial amount and often used first line. Duloxetine is also indicated for patients with neuropathic pain from diabetic neuropathy and also for patients with fibromyalgia. And one of these is called milnacipran, and this is only indicated for treatment of fibromyalgia. It's not indicated for treatment of depression. SNRIs block the presynaptic reuptake of serotonin and norepinephrine. And the adverse effects are very similar to the SSRIs: sexual dysfunction, insomnia, agitation. They can also cause a little more nausea and dizziness, so we tend to start with a low dose and then increase the dose. Venlafaxine can cause some hypertension due to noradrenergic effects. And we said you still have to watch out for serotonin syndrome. The next three rows on our table can be grouped together as the atypical antidepressants, which include some drugs you should be familiar with. Bupropion is an NDRI, a norepinephrine dopamine reuptake inhibitor. It blocks the presynaptic reuptake of norepinephrine and dopamine. But you can imagine that all that norepinephrine and dopamine tends to be a little stimulating. So it's a good choice to treat depression with fatigue and hypersomnia, but it's not used to treat anxiety. It's also indicated for smoking cessation, although in my opinion it doesn't work too terribly well. It's probably a little bit better than nothing, but it's not a magic bullet. For side effects, because it's kind of stimulating, it does tend to cause some insomnia and some weight loss, but that could be a good side effect. But one distinguishing feature is that bupropion does not cause sexual dysfunction like the SSRIs and the SNRIs do. So if you have a patient who's on an SSRI and they're just miserable from the sexual dysfunction, then switching to bupropion or adding bupropion could be a good option. It's also worth knowing that bupropion can lower the seizure threshold, especially at higher doses. So bupropion is contraindicated in patients who have a seizure disorder, and it's also contraindicated in patients with an eating disorder because those patients are more likely to have electrolyte imbalances that lead to seizures. Mirtazapine is an alpha-2 antagonist. It blocks alpha-2 adrenergic receptors. Now remember, alpha-2 receptors are found on the presynaptic adrenergic nerve terminals. And when you stimulate alpha-2, it reduces norepinephrine release. So blocking alpha-2 will increase norepinephrine release. Now, we don't really understand why, but despite all this norepinephrine, mirtazapine causes some side effects of sedation and also appetite stimulation and weight gain. So it's a great choice for depressed patients who have either insomnia or anorexia. It's also sometimes used in patients with cancer who have comorbid depression to try and help stimulate the appetite. Then the third group of atypicals are the serotonin modulators, which include trazodone and nifazodone, and there's one called vilazodone. Don't get too hung up on the mechanism here, but these drugs have a variety of effects on serotonin receptors. They act as agonists at some serotonin receptor subtypes and antagonists at other subtypes, and some of them also inhibit serotonin reuptake. I don't really think you need to worry about the mechanism too much. But the main side effect to know about is sedation. Actually, trazodone is often used as a sleep aid in depressed patients, more so than to actually treat the depression, because if you get a dose high enough to treat the depression, the patients really can't tolerate all that sedation. These drugs are also known for causing priapism, which is a prolonged erection, which can be very painful and cause permanent damage. So it's kind of the opposite of all those SSRIs and SNRIs that cause erectile dysfunction. You might remember the phrase trazobone to help you remember priapism as a unique side effect. The last two classes here are the TCAs and the MAOIs, which I'm mainly including for historical purposes and for completeness. These aren't really used much anymore. If I were writing an exam, they probably wouldn't be tested either. TCAs are tricyclic antidepressants, and they're called that because their chemical structure has 3 rings, so tricyclic. These block the reuptake of norepinephrine and serotonin just like the SNRIs do, but they're considered second line or third line for treating depression and anxiety nowadays because SSRIs and SNRIs have much better side effect profiles. Side effects of TCAs include anticholinergic effects like dry mouth, urinary retention, constipation, possibly some delirium in the elderly. Some TCAs are worse offenders than others when it comes to this. For example, amitriptyline has a lot of very prominent anticholinergic side effects, whereas nortriptyline or protriptyline are less anticholinergic. These can also cause sedation, they can cause sexual dysfunction again, and they can cause some weight gain. TCAs are also potentially very dangerous in overdose. They have a very narrow therapeutic window. At higher doses, they can prolong the QT interval and lead to arrhythmias. So think about it. If you're treating depression, which can cause suicidal ideation, and you're giving a drug that can kill people if they take too much, that's kind of a bad combination. These can potentially be lethal at as little as 5 times the therapeutic dose. So if they decide to take the whole bottle in a suicide attempt, they might just be successful. That's another big reason why we use SSRIs and SNRIs more than TCAs. Let's skip down to number 9 and talk about the findings in a patient with a TCA overdose. There's a little mnemonic for this, and these are the tricyclic drugs, and the symptoms of overdose are the tri-Cs, so 3 groups that begin with C. The first one is cardiotoxicity, which includes tachycardia, hypotension, conduction abnormalities, and arrhythmias. The next group is CNS toxicity. So these patients could be sedated, they could be obtunded, they can go into a coma, they might have seizures. Then the third bullet is anticholinergic symptoms, mydriasis, xerostomia or dry mouth, ileus, urinary retention. And again, these anticholinergic side effects are something you want to think about when you're prescribing these drugs to older patients, because older patients could be especially susceptible to anticholinergic effects. So if someone does come in with a tricyclic overdose, how do we manage it? Well, that's our next question. The first thing you think about are the ABCs. You can give activated charcoal. These patients need cardiac monitoring for at least 6 hours. They need frequent neurochecks. For labs, you definitely want to check a drug level, as well as checking basic chemistries to look for possible electrolyte abnormalities that might induce arrhythmias. And you're going to do an EKG to look for any arrhythmias. But the next 3 things are the main interventions worth knowing. If the QRS interval is prolonged and greater than 100 milliseconds, you give a bolus of sodium bicarbonate. If the patient's hypotensive, you're going to give IV fluids, and if that's not enough, you can give a norepinephrine. Then the last bullet, if the patient's agitated or having seizures, you want to give them benzodiazepines. But do not give phenytoin for a toxin-induced seizure, because phenytoin is not going to be effective. So benzodiazepines are going to be used for seizures with tricyclic overdose. Then, going back to our table one last time, the last group of antidepressants are the MAOIs, the monoamine oxidase inhibitors. Now, I'll bet you've never seen a patient taking one of these drugs because there's so many drug-drug interactions. Monoamine oxidase inhibitors inhibit the enzyme monoamine oxidase, not rocket science. But what does monoamine oxidase do? Well, it inactivates catecholamines like serotonin, dopamine, and norepinephrine. So MAOIs increase levels of serotonin and dopamine and norepinephrine. Now, we mentioned that MAOIs are useful for atypical depression, but we really just don't use them much. They work great, but the problem is that they have so many side effects and there are a lot of dietary restrictions, which we're going to talk about, and there are a lot of drug-drug interactions. For example, we mentioned that MAOIs can increase the risk of serotonin syndrome. But the main side effect to know about with MAOIs is hypertensive crisis, which occurs after eating foods containing tyramine. So how does tyramine cause a hypertensive crisis? Well, you have monoamine oxidase in the CNS, but there's also monoamine oxidase in the GI tract, which breaks down dietary tyramine. So if you eat tyramine-rich foods like a nice brown banana, but you're not able to break it down in the gut, that tyramine level is going to rise. And tyramine is an autonomic stimulant. So if it's not being broken down, it's continuing to stimulate the autonomic nervous system, and you're going to get hypertension and tachycardia. So there's a question in your study guide. What food should be avoided when taking MAOIs to avoid a tyramine-induced hypertensive crisis? Well, we talked about tyramine as a trigger for migraines, so this is the same list, just a little more detailed here. The classic ones are foods that are spoiled, pickled, aged, fermented, or marinated, so processed foods. So look at this list. Fermented cheeses, hard cheeses. Soft cheeses like cottage cheese or cream cheese are okay, so we're talking about hard fermented cheeses. Smoked meats or aged meats, sausage, pepperoni, that kind of thing. Chianti, most beers and most wines. Soy sauce, shrimp paste, and miso soup. Sauerkraut and avocados, and ripe bananas. Remember, green bananas are fine, but those ripened brown bananas get more and more tyramine as they age. Also, fava beans. So, no fava beans, no Chianti. Hannibal Lecter was not taking an MAOI. So, because of these dietary restrictions, we just don't use MAOIs much anymore. Then one last treatment for depression I want to mention is a non-pharmacological therapy, which is electroconvulsive therapy. ECT is one of those really misunderstood things about psychiatry. ECT is where you sedate the patient and you use electrodes on the scalp to deliver a current and induce a controlled, painless seizure. And this is not like what they show in old movies where it's traumatic and people are being treated inhumanely and they're tied down and bucking the restraints as they have a seizure. These patients are actually sedated and they're anesthetized, so the seizure is only occurring in their brain, not in their entire body. Now, the next question in your study guide says, what are the indications for ECT? Now, you can use ECT for patients with severe depression that's refractory to other treatment. So if they're on a couple of antidepressants that just aren't working, then you might consider ECT. It's very effective. It has about an 80% response rate. You can also use ECT for depression with psychotic features, for severe suicidality, where you can't wait 3 weeks for the antidepressants to kick in, then considering ECT first would be something to do there. If you have someone with depression who's refusing food and becoming nutritionally compromised, then ECT would definitely be something to consider. Again, you don't want to have to wait for 3 weeks for those antidepressants to start working. Catatonia is something that has a lot of evidence for the use of ECT. This can be both related to mood disorders that can cause catatonia, like depression or bipolar disorder, or even schizophrenia-related catatonia. So that also responds very well to ECT. And really, catatonia responds mainly to benzodiazepines and ECT, and that's pretty much it. Then some other times you might consider ECT would be, again, anytime a rapid response is necessary, particularly in pregnancy, where the woman may be nervous about taking medications. So ECT is safe and effective during pregnancy. And if a patient has had a good response to ECT in the past, that would certainly be a reason to consider it again. And we already mentioned bipolar disorder and schizophrenia. All right, now we're ready for the end of session quiz. So pause the video, work through those questions, then we'll go over the answers together. First question, how long must a patient expect to take an SSRI before they see improvement in their depression? So at least 3 to 4 weeks, maybe up to 6 weeks. Next, in TCA overdose, what can be used to correct the prolonged QRS interval and possible seizures? So you can use IV bicarbonate for the prolonged QRS interval and IV benzodiazepines to break the seizure. Next, which antidepressant matches each of the following statements? So the side effect of priapism, remember trazodone. So this is trazodone and those other serotonin modulators, but trazodone is the classic one. Next bullet says lowers the seizure threshold and can be used for smoking cessation. That's bupropion. Next one is appetite stimulant that's likely to result in weight gain. That's mirtazapine. The one that works well with SSRIs and increases REM sleep is trazodone again. Then the one that can be used for bedwetting in children, and we didn't mention this, but the tricyclic drug imipramine can sometimes be used for bedwetting because the anticholinergic side effects will cause some urinary retention. The biggest downsides are it's only approved for short-term use, and then when you stop the drug, the patient's going to start wetting the bed again. Last question, what are the symptoms of serotonin syndrome? So we mentioned altered mental status, autonomic excitation, and that neuromuscular hyperactivity, including myoclonus and ocular clonus. All right, that's it for now. I'll see you next time.
And now, here's Dean with the weather.
Thanks, Jim.
Hello for News 12. I'm here to give you your daily weather forecast.
It's time again to play Name That Drug. What drug is associated with the following side effects? Dry mouth, tinnitus, blurred vision, mania, time's up. The drug is amitriptyline. These side effects are mostly due to amitriptyline's anticholinergic activity. Thanks again for playing. See you next time on Name That Drug.